This is my final case. Quinn broke my heart with how serious she was about her concerns, and it represents the difficulty that therapists and I'm sure doctors struggle with every day when someone comes in and says, I have to get back to what I was doing and I want to get back now because it's everything that I'm for. And in her case, running was her antidepressant. She had tried other things and she broke down in front of me saying, I've got to get back to running. But her symptoms, for those of you who are out there listening, you're going to nail probably with just the story of her symptoms. When she first stepped out of bed in the morning, she had severe pain for the first little bit, but after about 10 or 15 minutes, that pain dropped down to a modest level. That pain worsened to where she wasn't even able to stand on it very long by the end of the day. And her drive to run took her to the point of where she simply ran through the pain and hit a point where she couldn't do it any longer. So she went to her family doctor who tried PT, put her on non-steroidals and put her on an orthotic. She, of course, went back to running her 5 to 7 miles, and it just didn't get better. So she came to me and said, I have to have help. What can you do? What can you look at? So I'm going to see if I can't take this to the diagram. This is going to be a segue into having you take a look at the plantar fascia. So in this diagram, you're going to be able to see that the probe and its call out is going to be coming in the direction of the heel itself, but this time on the inferior aspect. And what I want to make very clear to the listeners or the viewers is that the importance of the fat pad. In the case of the heel and the heel fat pad, think of it like every time the foot falls, it's like a mattress that's under a falling body. And think of running and jogging is just a series of interrupted falls by the heel smashing down. So as you take the probe, I want you to orient it so that one part of the probe is in part on the bone that you can palpate on either side called the calcaneus. We're going to be looking for that hyperechoic bone of the calcaneus. The very top of the screen is skin, of course. That almost cloudy looking area above the bone is that fat pad that we were talking about. What we're looking at is a beautiful view of that fascial fiber coming from the right, all the way from where it attaches to the flexor tendons.
Maybe and a little more depth here?
There we go. Just a tad bit more so we can see some of that, the quadratus plantae muscle underneath that. So if you can now attempt to just gently take the probe and go toggling, where we go heel and toe, I want the viewers to watch the movement of that fat pad as it protects that tendon down below. Now I say tendon. Greg? Yes, that's perfect. It is long strand collagen. It's called fascia because it's really an aponeurosa or an aponeurosis. However, it's the dimension. And I also want to show you that if we take a look at the white dots to the right, the dimension here is, I'm going to guess, maybe 3 millimeters, because those white dots are, oh, perfect. Check it out. From that point there to the actual periosteal point, 3.4.
Did I measure it right?
Know, close enough. Okay. Yeah. But what I want to have you point out to you is that the fat pad on a healthy plantar fascia should be twice the thickness, or somewhere between 0.5 and 1 centimeter. And as you, again, the way we measure that is if you remove some of your pressure from the probe, because we want to allow that fat pad to come back down. There you go. Now you're seeing the full dimension of what the fat pad is going to do. Now, if you just gently rock the probe forward to backward, you'll see that fat pad moving over the plantar fascia. Because the plantar fascia is so easy to see, you can immediately say, is it plantar fasciitis? And that's important because the differential on that means it could be the spine, it could be the posterior tibial tendon, it could be the talar, the tunnel, the tarsal tunnel.
Other things you could look at with the ultrasound while you were there, potentially?
Absolutely. And in fact, if they're having heel pain and you can measure the plantar fascia, and that plantar fascia is well below the 0.4 millimeter, 0.4 centimeters, you can go right to that. I wanted you to see what a large plantar fascia looks like, because on the model there, you didn't see it. But if you can take a look here, this is a 1 centimeter thick plantar fascia. You can see that it comes all the way down from the point of the calcaneus here, all the way to here. And you can also see that fat pad itself has deteriorated some. I'm going to move on because I want to get to the meat of this particular case study. And I'm going to show you the scan and how it was with Quinn on my first session. This was Quinn's heel, top left. You're seeing the plantar fascia, and it was clearly enlarged. It was 7.38 or 7.4. And I want to draw out her passion and how she basically kind of told me how fast to get her better. And that was that she said, I've got to get back to running, but I will stop, I promise, if I can get back to running in 6 weeks. And this is where I'll tell you the beauty of POCUS is to me, because I took almost a fatherly attitude. I guess it would be more like brother. She's middle-aged and I want to think I am. And I came down and I sat alongside her and I said, listen, the only way we're going to get you back to running is if we take a look at this picture and first ask your feet what's wrong before we then go and interrogate what your heart wants to do. And so she did buy into the fact that if I can look at her feet and show her where the problem is, she's at least willing to consider that. I'm going to now take us a little bit further, I hope. I want you to see that the power Doppler is showing fluid flow between the fat pad and the plantar fascia. Now, when that happens, it tells me that really this is a function primarily of breaking down that fat pad, and the inflammation was occurring right in this area here. So I recognized, and I'm going to see if I can't keep going here a little bit faster. The next one is going to be up here. This is the short axis view, and you're going to see here that this is the dimension if we're cutting it, let's say, like a baguette. Instead of julienne fries, we're cutting it in an axial plane or short axis. Anyway, with this in mind, I was able to talk to her about where we want to go. And I'm going to take us to the second scan, which was about 4 months. That is, providing I can get us there. But clearly we knew that it was plantar fasciitis and that there was a fat pad degradation. There we go. But I want to show you that in 2 months, she was able to reduce the size of her plantar fascia down to about 6 millimeters. We were starting to see some fat dimension forming, and we actually had her at this time walking because she was able to tape her heel to pull some of that side fat down to underneath the point of her heel. And we were able to get her into some good shoes. And of course, I gave her the affirmation that she was doing great and that she was not abusing it, because I could see that there was no fluid in that area. And I also want you to see one important point. At 2 months, Quinn was still having disabling pain in the morning. Now, a patient that goes 2 months and still has that symptomatic pain, if I did not have access to the ability to assure her that she was on the right track, I wouldn't have been able to keep her as my teammate in getting her back to what she wanted to do.
Now, and you can't undersell, you mentioned it's 6 millimeters compared to 7 millimeters, which, doesn't sound like much, but as a percentage, that's a pretty significant percentage. And to be able to perceive that subjectively versus actually showing the change in the measurement, it's a pretty profound, right?
It is very profound. She was feeling some improvement, but not nearly enough to nourish her hunger. But we were able to get her to walk, and she recognized that she had some ownership. Now, I did not scan her again for 8 months because she was actually in a satellite clinic, and she was doing 75% better at 4 months, and they were able to get her up to even moderate running at about 6 months. She was having no pain at the time, and my feedback to her was, I wonder just how that plantar fascia looked when I scanned her the 3rd time. And so clearly, as you can see, we're down now in this particular view, which was a short axis view, to about 5.5 millimeters. And it does make me realize that we don't have to have textbook perfect thickness in order for a person to be out of pain. So sometimes it edifies the clinician. Yes, I'd love to have her back to where the textbooks say it should be, but that's just not the way it is. However, I can tell you with all honesty, she would have never been compliant and staying focused on what I was having her do. And her joy that she had for accomplishing this task was just really rewarding to a clinician. And every one of these, I guess what I put these differentials in for was for people to realize that if I would have put the probe on the plantar fascia and I would not have seen a small fat pad, or if I would not have seen that narrow plantar fascia, these are other things that I have actually found that do make us think that.